Good evening, everyone. My name is Linda Houle-Robert, and I'm the Education Director with the MS Society. So I'm happy to see such a big group here this evening. We would like to welcome everyone at this event. We've got a full agenda, and we hope that this event is not only informative and educational, but also useful. We have a lot to cover this evening, so we will try our best to keep on schedule. We will begin with Dr. Sautel's presentation, followed by Krista Cochran's, and finally, personal testimonies from Adam Goldberg and Fiona Sparrow. So I'll start with I'd like to introduce our first presenter, Dr. Eric Sautel. He's an associate professor in urology based out of Ottawa, the Ottawa Hospital Civic Site. He completed his urologic residency at the University of Ottawa, followed by a clinical fellowship in urodynamics and reconstructive urology at the University of Toronto. He has treated a diverse range of complex urologic reconstructive problems. The main focus of Dr. Sautel's practice is male urethral stricture disease, urethral injuries and trauma, urinary diversions, and urinary incontinence. He is also interested in the transfer of care of young adults from the care of pediatric urology to adult urology. So thank you very much and welcome.
Thank you.
I apologize.
I have a lot of interests, as you might see, and actually the fellowship that I did was used to be called a neurourology fellowship. It somehow got transferred into reconstruction and urodynamics, but back in the day, that's what they used to call it, the neurourology. I think they were getting mixed up with the neurologists, and then we get the wrong kind of referrals. So let me just double check this thing. Good. So now I know a lot of faces that I know here, and that makes the room a little more friendly for me. But if you haven't met me, I work at the Civic Hospital, and I let most patients call me Eric, so I can't see why we can't continue that here. So I'm pretty informal, but we're trying to keep all the questions together when we're done the first two talks. So, but if you have something dire, just please let me know. It's interesting, but not to try to highlight bladder problems as being important in people with MS, but it turns out there was a recent study that looked at quality of life issues in patients with MS, and it was identified that up to 80% of patients with MS have bladder problems, and so this was quite a surprise, especially to the neurologists and even the treating neurologists in the MS clinic, that bladder issues were identified as being one of the most important, if not the most important, quality of life issue in their patients. I had the opportunity to speak with the neurologist here in Ottawa from the MS clinic at a talk about a week and a half ago that I gave, and was really shocked by their interest in the topic, and especially in the urology side of things. And that just underlines that to me, that this is a rather important and if not dominant issue, especially in regards to quality of life with multiple sclerosis. And there are a lot of barriers to receiving treatment for this, and certainly embarrassment is probably one of the number one roadblocks to creating a conversation with your physician, whether that be your primary care physician as your family doctor, or even your neurologist, both of whom are very well trained to help you down the road to improve things. But if you don't talk to them, then that treatment doesn't get initiated. Most discussions, and on this slide pulls 9 out of 10 discussions about OABs for overactive bladder, but most of those discussions are initiated by patients, not by physicians. And so if you're not able to talk about it, then often these issues fall to the wayside until the next appointment and don't get dealt with. And those problems can just continually build if they're not addressed. That 9 out of 10 statistic was right from that AUA, stands for the American Urological Association meeting. That was something that was brought up there. Originally we were going to do the patient presentations here, so we're not going to do that today. So when we look at the types of bladder problems, specifically in MS, we're really talking about two major categories of problems. And the first category is the issue of, I can't store my urine. And we break it up that way because really what that means is incontinence. I'm not able to hold my urine like I'd like to. I can't store it. The other problem, which is less of a complaint from patients, but maybe more of a concern on the medical safety side of things, is I can't empty my bladder. So patients are literally in urinary retention, not able to empty their urine. It always surprises me as the years go by and the patients that I meet how similar these two things can appear to each other. What can seem like, what the majority part of our discussion will be about overactive bladder, which is, having to go urine frequently to the washroom or urgently, can sometimes actually be someone who's not emptying their bladder at all, and it just seems that way. So something even for me that can be humbling to sort out, but quite important to make a difference between. I was asked to talk, I'm not trying to overcomplicate the slides here, but I was asked to talk a little bit about how the bladder works and why some of the medications that we use work, and how some of the other therapies work. But essentially the bladder is a hollow vessel, and its wall is built out of muscle, and that muscle has different neurotransmitters and receptors in it. And the medications we use, and they're not important, but they're highlighted here on the slide, affect different parts of the bladder and affect its function in different ways. Hopefully helping you along with any of the problems you have, whether they are problems emptying or problems storing that urine. Very much the same, again, not trying to belabor the issue or complicate it. I put this slide in because we might come back to it to talk about things later on. But there are things that influence your bladder and how it functions that are both medication, but obviously those are of origin of the neurology that occurs in your bladder, the nerves that run to different sections of the bladder, and the different nerves that stimulate the bladder. Oops, there we go, we got an animated slide here. So here we have the normal bladder, again, this hollow muscle. And when we look at problems of storage or problems with what we call an overactive bladder, we see that at an inappropriate moment that bladder contracts as though it wants to empty. And that may be, or usually is, not in your control. And so that's often the basis of having symptoms of urgency. And that's the main clinical symptom associated with an overactive bladder, or one of the main problems of here that we see in MS. So overactive bladder, or that symptom of urgency with a bladder that's squeezing on your urine trying to get it out, ends up being about somewhere between about 40 to 50%, even in some papers 60% of the problems, urinary problems with patients with MS. The defining symptom really is the urgency, and the others, things like urinary incontinence, urinary frequency, and sometimes the last one, nocturia, which means getting up at night to pee. Those are all secondary to that primary urgency issue. So the key here to remember is to talk to someone. And really that involves a medical evaluation. And that may not be a very extensive one. And I'm not here to try to scare someone and say, oh my goodness, it's going to be a big workup and a big scary thing to go through. It's really not. But the idea is to talk at least to your family doctor. And again, as of 2 weeks ago, to my surprise, apparently to your neurologist as well, who really deeply care about these problems, about what to do. What do I need to check before I get this looked into? It's important to try to get an early evaluation, so don't be shy. Get it looked at early. And by doing that, you can avoid a lot of complications if you're perhaps one of these people who are not emptying their bladder. That's the group of people that I worry about the most. That's as far as having urine infections, as far as having renal failure or injury to their kidneys. That's probably the first thing to look into. Remember, and this is a huge and important topic, almost everything I do in urology, although some of the stuff gets quite elaborate and medically important, but most of it's quality of life. And let's face it, a lot of these problems, especially the incontinence, is about quality of life. And it's about that emotional component to it. It's about getting to the store without wetting yourself and having to go back and start again. So issues of hygiene come in secondarily, but these are very important issues. And that whole idea about self-confidence and being a whole person and having the confidence to go out and conquer that world and be out there, it's a big issue here. And that's central to us. There are people who care, and that's what you need to know. How does this work? Well, it's hard to pin down exactly just by discussing with someone what their problem or their issue is in MS because of the varied presentations and the varied injury that can occur to the different nerve tracts. This is just a graphic showing that. But basically, there's an interruption to the signal from the brain to the brain. There's also interruptions in signals to different reflexes in the bladder. So that's why we have to evaluate these to see what's going on. Now, there are different coping strategies, and not everything we do has to be related to medication or injections that we'll talk about or other surgeries. And Thankfully, we have an expert here to help us along with that, with a great talk and discussion, so we'll talk more about that. But you know, briefly, we're talking about things like dietary and fluid changes, some very simple things we can do to help with adaptations for patients. Behavioral changes in how they deal with their bladder, which we'll elaborate on, and other, again, I'll spend more time talking about the medications that are available and other mechanical aids to flow. That was kind of a code word for catheters and things of the sort, which, you know, I didn't turn into a huge part of this discussion, but it can sometimes be an overwhelming and very important area dealing with the bladder and urine. Catheters, in and out catheters, indwelling catheters, and that kind of thing. So these are all methods that we use to manage them and are so varied individual to individual, but do become very important to your lives as you go through these scenarios. I mean, you have to deal with them, you have to face them, and they're all new and different things that you have to cope with. Oh. There we go. There are a lot of medications, and I'm not here to, you know, focus on one or get into it. The first run of medications, I don't know if any of you are on these medications. You may or may not recognize them from varied sources, but I tried to create a list there that's you know, pretty common medications that are used for treatment of overactive bladder. After you've done a lot of the more conservative and behavioral changes, they become an important thing to try in order to try to improve your quality of life. And they really are for that, quality of life improvement, to help you leak less, to have you have less urgency and frequency. And these medications are, for the most part, taken orally, which is pretty easy to deal with that way. There's one patch in that group. There's also one emulsive gel that is used. But nonetheless, these are all fairly simple delivery methods for people to use for overactive bladder. They do work fairly effectively as a medication option and are important. We'll talk more about it as questions come up. What do we do if the pill doesn't work, or if the cream or the patch doesn't work? Well, there are other options for people with overactive bladders, including, I guess, what a lot of the topic was tonight, or the goal tonight was to mention the presence of the use of Botox. And I think there's even a patient later on today who will talk about that and their experience with it. And certainly not the focus of today, unless somebody has questions to discuss, but some people require surgical interventions, and not everyone's situation is the same as the others. People have different levels of severity of the problem. They may try different modalities, and those modalities don't work. The simple answer doesn't work, and sometimes we have to find a solution for that. Again, quality of life and issues of quality of life, especially with regards to continence, depending on how much that's bothering someone, sometimes has to be taken very far. And yes, there are people who've gone through quite extensive surgeries to achieve dryness and control in their lives, because really it is about control, and it's about having a good quality of life and having the confidence to go out and live. And if you resign yourself to a status that makes you unhappy because of incontinence or bladder issues, then that really means that I've failed in what I do. I mean, the goal is to get someone back to a level of quality of life and a level of care that makes them happy and lets them get out in the world. So this talk was a little bit, was from another talk, but again, that's the Botox part, which is the injection, the secondary layer, secondary kind of level used for overactive bladder. It's used currently for people with MS. It is indicated and covered in Canada, and does work very effectively for this. So I don't know if any of you are using the medications and having problems, but it's certainly something to consider as far as treatments for overactive bladder. How does Botox work? Very simply, it inhibits the nerves that are giving a signal to the bladder to contract when you don't want it to. So hopefully to get you control, even though the medications don't work, and even though your bladder doesn't want to listen to you. We give it, you know, people ask that, and well, that's great, you've got Botox, how do I get it? Well, it has to be done with a camera looking in the bladder, and literally, and that image shows it, a very small skinny needle is used to literally inject it in different places in the bladder. And that's its delivery method, which I guess is in a way is one of its downsides, but remember that the trade-off to that is you don't have to take a pill for several months. And so even though it's a little bit invasive to get it in there, it does have its trade-off, and especially if it works, and if it works very well. You also have to take it a lot less often. So although this says you may have to have a retreatment in as little as 3 months, most patients seem to last about 5 or more months. Somewhere in the 5 to 6 month range. It can last up to 9 months And so, you know, everything has its trade-offs, and one of the good things about this medication is it doesn't have to be taken very often. And it is, yeah, it's very safe. One of its major problems is that, ironically, sometimes it works a little bit too well, and the bladder no longer wants to contract. So some people do have problems with being able to empty their bladders. And so they may have treated a situation where they're leaking and having a lot of incontinence for dryness, but the bladder may not be emptying well, which we also have to deal with. But again, that problem is upfront and consistent, and otherwise it's actually a very safe medication. So that's it for my part. I think let's just go on to the next part.
Okay.
So we'll just hold the questions if you do.
Thank you very much, Eric, for such an informative presentation. Our next presenter now is Krista Cochran, who was born and raised in Ottawa, Ontario. She is a registered physiotherapist who graduated from the University of Western Ontario in 2000. Krista has been dedicated to improving the quality of life of those suffering from urinary incontinence and pelvic pain. She is determined to provide a voice of confidence and dignity to all her clients. Krista has worked in the Ottawa area for over 11 years in both orthopedic and women's health practices. Krista is married and stays young, raising her 2 young sons. She's an active community volunteer. So let's welcome Krista.
Hello everybody, my name is Krista Cochran and I'm a physiotherapist in Ottawa. I work at Pelvic Support Physiotherapy with Caroline Allen. She was going to do your talk today, but you've got me today. I want to talk to you about what physiotherapy can do and how it can help you with urinary incontinence. I'm going to go over a little bit about the different types of urinary incontinence and what we do to help each type. Again, urinary incontinence is the involuntary loss of urine. It affects 3.3 million Canadians in the general population, 1 in 4 women and 1 in 9 men. 80% of people with MS are estimated to have bladder problems. Again, the storage component is the urgency, frequency, nocturia, getting up at night, and incontinence, whereas the emptying problems can be hesitancy, having difficulties getting started to the urine flow, retention, where the bladder is stretching and holding too much urine, and incomplete emptying. Social consequences, again, were touched, but the depression and isolation, worrying about intimacy, fatigue and sleep deprivation if you're getting up multiple times a night. It can be one of the leading causes of institutionalization in the elderly, and it can lead to skin breakdown, infections, falls, and different things like that. What can you do about incontinence? The first type of incontinence I'm going to talk about is stress incontinence. And stress incontinence is the one most people hear about. It's the incontinence you get with moving, coughing, sneezing, any of that exertion. So that is like a mechanical problem. The muscles in the abdomen are pushing down on your bladder more than the sphincters in the pelvic floor can hold up. So if you're pushing down more than you're holding up, you get leaking. So that's getting out of a seat, coughing, sneezing, that kind of leaking. The things we can do to help that is, one is we can strengthen the pelvic floor. If we strengthen the pelvic floor, it holds the sphincters and everything tighter, so then you're not having leaking. But we also teach you how not to bear down when you're getting up. If you're getting up going and pushing down, that's causing leaking, whereas if you get up breathing out going, then you don't have the leaking and you don't push down. So we teach you not to bear down, and we teach you to strengthen the pelvic floor, the 2 parts of that equation. We can also teach you to have better coordination in your pelvic floor muscles. So if you're going to be coughing, sneezing, or lifting, then you can contract your pelvic floor. As you cough, you contract and then cough, instead of contracting your whole body, especially those push-down muscles, and then have that big push down when you cough. You want to be supporting from beneath and holding that up. Urinary urge incontinence that we've talked about a fair amount is more a coordination problem. It can have to do with the spasticity in the bladder that's often seen in MS, and that can be treated with the doctors. But another time when we get urgency is when we signal the bladder to contract at the wrong time. And that can be walking past the bathroom or getting home. You were perfectly fine sitting or before, but as you get closer and closer to the toilet, we start thinking, I'm going to pee, and we send down that signal to pee. And we don't want to be doing it, but we're sending it down at the wrong time. So if its signaling problem is causing us to pee on the way to the toilet, that can be fixed with relaxation techniques, distraction techniques, and those types. This is not a sign you want to need to see when you have to pee. Again, so this is going to be that pushing down of the bladder, or the contracting of the bladder, while you're still trying to hold. And that makes a problem. We want to try to relax that bladder again. And the different things we can do to relax is taking deep breaths. If we're panicking the bladder as well. It's not going to relax and fill some more, it's going to stay contracted. So you want to take deep breaths and try to calm the bladder down. You want to distract yourself. If you're thinking pee, 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 you might be sending that signal down to pee. If you're counting backwards from 200s, focusing on different things, saying a poem in your head, distracting yourself in general, then you can distract your mind from that urge to pee and try to calm that down. You can gradually start, if you get good at relaxing and getting that urge to go away, then you can gradually start deferring the void and going a little bit further between urinations if frequency is a problem. You don't do that if retention is the problem. Functional incontinence. Functional incontinence is more, there's a physical barrier from getting to the toilet. If you are sleeping on the one level and the toilet's on the other and you cannot get down the stairs, that's a functional incontinence. If you cannot undo the pants, that's functionally going to make you incontinent. Those are more assessed better by an OT assessment, hand bars, different ways of getting a commode closer to the bed, and the functional ways to get to a toilet safely and effectively. Overflow incontinence is that retention. So that is when the sphincter and pelvic floor can be too tight and the bladder is stretching and stretching and stretching. So if it stretches too much, it might just start leaking all the time. It's not leaking with coughing, sneezing, moving, it's just kind of leaking a little bit here all the time. So often that's a retention problem. And once that bladder is stretched too much, then it has a difficulty emptying. So if the retention goes untreated, then the bladder gets less and less effective. So the catheterization and stuff like that will help to get that bladder in a better functional range so that when you want it to contract, it's strong, not big and stretched. So again, this is just kind of showing the bladder's trying to go, but the sphincter's too tight, so it's not letting it come out. So we want the pelvic floor and those sphincters to work more properly. This is a picture of the pelvic floor. This is a woman lying on her back. So you have the urethra at the top, the vagina, and the rectum. The men's pelvic floor looks similar without the vagina. So that bowl of muscles is holding in your organs, and it is wrapped around the anal sphincter, around the anus, and around the urethra. So when you have dysfunction in that pelvic floor, you can have bladder problems, you can have bowel problems, and you can have sexual problems. That pelvic floor can either be too weak, so that it's not supporting properly, and that leads to that stress incontinence, or it can be in spasm. And you can have many of those different types of incontinence from spasm. As a physiotherapist, we see a lot more people with a pelvic floor that is too tight than is too weak. If your pelvic floor is in spasm and too tight, it doesn't mean it's strong. It just means it's not functioning. It's just staying there all the time. It's not going up and down, and it's not a strong pelvic floor. The signs that your pelvic floor might be in spasm could be that you're having difficulty emptying the bladder. It's hard to relax and to get the urine to start flowing. You have difficulty or pain inserting a catheter. For women, if it's painful having intercourse or inserting a tampon, bowel issues, constipation, anal fissures, and hemorrhoids can all be caused problematic if the pelvic floor is held on strong and you're trying to push that through. And lower abdominal discomfort is quite common as well. Different things you want to do to help your pelvic floor relax. If you're holding a lot of tension in your chest, then, or in your abdomen, then your pelvic floor is often being held up too. So you want to start with decreasing the tension in the rest of the body, taking deep breaths and putting less pressure in the abdomen. Practicing that diaphragmatic breathing can help. Visualizing the pelvic floor, your brain can't see your pelvic floor moving, so if you see a picture and you can visualize it goes up and it goes down, it goes up and goes down, and picturing it dropping down when you're trying to void, that can be helpful. Tightening the pelvic floor a little bit before you relax it, so your brain knows where it should relax. If you just say relax and you don't know it's tight, then it's hard to find it, so sometimes finding it first and then letting it go can be helpful. If you have a spasmatic or a tight pelvic floor, doing Kegel exercises is not going to help. It's going to make it more tight. So you think it's weak, but it's actually spasmatic and you're holding it at 8 out of 10, and to strengthen it will just make you hold it at 9 out of 10. First, we have to learn to relax it and how to let it go, and then we can make it stronger again. If you have a tight pelvic floor and you can't feel that relaxed, then seeing a physiotherapist, a pelvic health physiotherapist, can be helpful. This is a good position to help try to relax the pelvic floor and the abdomen when you're trying to evacuate or void. You want to make sure that you're not tightening your stomach and pushing down. You want the stomach to relax and fall forward, and then you can drop the pelvic floor more easily so that you can void or evacuate. The squatty potty is, you'll have this slide, is a neat little device with all the raised toilet seats and everything. Doesn't have you in an optimal position to void. Having your legs up higher is better, and it's like a plastic stool that kind of goes around the toilet, and you can bring it out when you go to the bathroom, put your feet on, and then it goes back in so that you don't have to trip over it. It's just a plastic stool that kind of goes around a toilet. It's kind of a neat device. Different lifestyles interventions that you can do that will help with incontinence. If you are not having urgency, so you have your urgency under control and you can make it to the bathroom each time and retention is not a problem, then learning deferring techniques so that you can defer voiding is a good concept, but you don't want to be sitting there holding on to your bladder. If you're holding your pelvic floor and your abdomen tight, it doesn't make a happy bladder and it puts more pressure. You want to be nice and relaxed. Drinking lots of fluids. You don't want your urine concentrated. Water makes the bladder happy, but things like caffeine and alcohol and carbonated drinks, they can irritate the bladder and make them unhappy, so it doesn't want to stretch nicely. Avoiding constipation. Diet, again, fluids and diet, fiber, having 25 to 30 grams of fiber, which you can find different fiber charts on the internet very easily. Weight loss. A study showed that in moderately obese women, that a 5% change in body weight could make a 50% change in urinary incontinence. And that's in the general population, not just MS. Avoiding smoking and that proper toilet position can also help. The take-home message is that urinary incontinence problems are common in the general population and especially common in MS, and that just because you have a neurologic condition doesn't mean that there's not other things that you can do to help. There's no negative side effects of seeing if your pelvic floor and your abdomen are working properly and to your advantage, and you're not alone, and we're here to help. If you have any questions, we'll be available to answer them.
Thank you very much, Krista. So now I guess we'll proceed if we have any questions for either Dr. Sautel or Krista. Do we have any questions?
Well, I appreciate all the information that you've been giving us. There hasn't been any real talk about sexual function and what happens if you lose your bladder completely during intercourse.
Yeah.
I've never been able to talk to anybody about that.
And I agree. I mean, it's there's so many levels of issues of embarrassment and things that interfere with these discussions. And it's a huge issue. And what that ends up doing is when it does interfere with intimacy, it's just another issue of quality of life that we don't talk about. We don't talk about here. We do talk about it in the office more, and they're very important. There's no, I can't really give specific advice about it unless they come in for evaluation. But people are there to. We know this, and we're geared to that in the office as far as adding that to the list of priorities of why this is important to you.
So in other words, seeing a specialist would be a good idea?
I think it'd be really important.
Okay.
And I think you can get a lot of yield and improvement in your quality of life from that.
Yeah, nobody's ever, I think I've seen several neurologists and only one of them has ever even asked about it.
This topic is in its infancy, just sexual function and neurologic problems. At the rehab center, there is, I think she's a nurse who had her master's degree, who has gone on, and her master's degree was about sexual function in people with spinal cord injury. But it's a whole dead zone with regards to other neurologic conditions, and that doesn't mean they're not there, and that doesn't mean they're not very important. So yeah, please by all means pursue, and it's very important, just as much as any other issue. Okay, I encourage you. Yeah.
I just have, I guess, a quick comment and a quick question.
Yeah.
The first one relates to what you were talking about, but not specific sexually. It had to do with seeing a physiotherapist, and I was concerned I was going to leak on her table, and she was awesome. What she said to me was, "So I get a towel, I clean it up, and we move on." You know what I mean? But it made me feel that I could relax more. So it was hard for me to sort of initiate that conversation, but in any event. But my question has to do with, and maybe it's not appropriate to ask it now, but has to do with female urinals, I guess? Not urinals, sorry. Do you know what I'm talking about? Like, if you can't make it to the washroom, you know how they have female, is that what it was the right word? Is it?
Are you talking about like a handheld?
Yes, thank you.
Yeah.
Is there any that actually work with women's body parts?
Well, I mean, they're hard to find ones that are especially,
Yeah.
it depends what you're looking for. If you're looking for something that it simply directs the urine, or if you're looking for something that is actually a holder receptacle.
I'm looking for something that actually can, like
for bedside.
yeah, exactly. But
Yeah.
actually that you can stand up to use, like honestly.
Yeah, they do exist, but they're kind of hard to find. The hospital uses it's an incomplete device that I could try to get together contact for it, but it is basically an adapter with a tube that you could put anywhere, I guess, if you want.
Oh, okay. Yeah, no, because I have checked different places. I was just
it's very hard to
curious.
find. Usually in the medical devices area rather than other.
Okay, thank you very much though for
Yeah,
entertaining it. Thank you.
Is there anything we can use for traveling?
So the question is there anything to use for traveling of the same sort?
Yeah.
Yeah. Well, there is. I mean, I don't know if you. Yeah. There is a device, a handheld device that's basically an adaptive funnel to use at a urinal. I'm sure that is that kind of what you were referring to before. There are very few that are kind of like a bedpan or a handheld thing that you see for men, and it's true. So not entirely, but there is a travel device that it's like a coupling device, ends up being a cone to direct into a urinal standing. So not really, nothing convenient anyway. Sorry, can I finish that one? Unless you do CICs or unless you're doing clean intermittent catheterizations, there are bags that are fused to the catheter that are a sealed unit that some people are using for travel. Sorry.
I guess this is a question for Aaron. You had a whole list of drugs up there.
Yes. A lot.
And with any type of MS drugs, there's always lots of side effects.
Yeah.
What are some of the side effects that you might see with these drugs?
Those drugs, for the most part, amazingly enough, are all except for one derived from the same basic type of drug, an anticholinergic. And most of those have with them, especially side effects like dry mouth, constipation. There are a few other things, even urinary retention, ironically. So again, you can't pee. The other one, there was one at the bottom of the list that was, it's a new drug, different type of receptor that's approached. And it doesn't have dry mouth, it doesn't have constipation. It actually has very few side effects, but the problem with it is it's new and it's not yet covered, so it's kind of in its infancy. But it's really two categories surprising from that whole list. I think there's something like, there's close to 20-something different derivations of anticholinergics and only one of the other type.
I guess two questions. First of all, I often find urgency at both ends at the same time. What's your sort of starting the process off, and how does that happen? And the second question deals with the pelvic floor. What exactly is it? How do I relax it? How do I make it behave the way I want it to behave, rather than let it take control?
So the pelvic floor is a group of muscles at the bottom of the pelvis, and it surrounds the rectum and the urinary sphincters. To know if it's going up and down properly, you really need to have a physical assessment. I can't tell by looking at you or by you trying, I can tell if you're doing it wrong, if you're doing all these extra movements, but I can't tell if that muscle is high tone, low tone, if it's functioning properly without doing an internal exam. So to get an internal exam, we can tell if that is functioning properly. And during that exam, we can say, well, this is when it's up and this is when it's down, and teach you to have better proprioception so you know when it's up and when it's down. So that's really the only way to tell you, to show you if it's working properly. And what was the first part of your question?
Both ends at once.
Both ends at once. If you are having urgency, if you're having incontinence or urgency, incontinence could be that you are pressing down and it's pushing down at both, so that's the stress incontinence that you're pushing down, or
It's happening when I'm out shopping, for example.
it could be shopping, if you're pushing down, there's one thing, but urgency as in I have an urge, and then you're kind of increasing the nervous system and getting it all excited, can be making it worse. So it's taking a stop and taking a deep breath, distracting yourself and trying to get that urge to relax can be helpful before you run. If you are running to the bathroom going, I'm going to go, then you might be telling yourself to go on the way. Whereas if you're sitting there confidently, relaxing, then that can be helpful. If the bladder is an actual spasm because of a neurologic condition, then that is a bit different than you seeing a bathroom and thinking, oh, gotta go, and having more emergency the closer you get. That is more something that we can control with the mind and control with calming that nervous system down. Does that answer your question?
I think so, yes. Thank you very much.
If I might add also, the area of the rectum and the bladder are innervated by similar nerves. They actually run along the edges of the rectum, called the pelvic plexus. And sometimes they fire off a spasm at the same time. It literally feels like everything's falling out the bottom. And so that's literally a bladder spasm, but it can involve the rectum, and it can be quite dramatic.
It is.
Yeah.
I have a problem that is, it's not regular, but on occasion, no matter how much or how little I've drank through the day, come about 7:30, 8 o'clock, I'll have to go to the bathroom every half hour. And it'll go till 1 or 2 in the morning. And finally I'll be able to go to sleep and get through the rest of the evening. But I could understand there are nights I'll be out playing cards and I'll drink a gallon of water. I kind of expect to be up more often. But there are times when I drink very little and I still have that same reaction now. Thankfully it doesn't happen every day or every week, but it's often enough to show some sort of a pattern, and I'm not sure if it's MS related, if it's bladder related, if it's prostate related, the whole 9 yards. Is that something that you've heard of in your...
Yes. Oh, yes, I do. And you're certainly someone that I would love to help and evaluate. I mean, I think, have you mentioned this to anyone, like any of your healthcare providers?
Yep.
And you know, I mean, listen, if you're not getting resolution from that, certainly it would warrant a referral. I mean, I think that kind of interference in your life is quite extreme, and I certainly would have to look into a few things to make sure that you're emptying and that your bladder's otherwise functioning well. But I certainly think that you'd be geared towards getting help,
Okay.
and there to help. Yeah.
Hi, Dr. Saltel, I'm just wondering if you could address a little bit, like if an indwelling catheter isn't working anymore for you, could you just talk a little bit about the
Yeah.
suprapubic?
Sure, absolutely. And then there's a whole, I mean, that, okay. So should I repeat the question? Did everyone hear that? So we were talking about indwelling Foley catheters, and that wasn't really talked about, but this is a huge issue in the MS population, depending on what stage the person's at, what level their disability is, how they're affected with their bladder. And indwelling catheter essentially has a lot of problems associated with, such as recurrent urinary tract infections, and it can often worsen and even trigger bladder spasms. People have situations where their catheter, they're voiding out their catheters because of this kind of spasm, which, by the way, if that last line sounds familiar, it certainly would be important to consider suprapubic tube so you don't harm yourself further. But the suprapubic tube is simply a rerouting of the, I don't know if we have, may I go back?
Yeah.
Suprapubic tube is simply a rerouting of, I don't know if there's an abdominal image here, but a rerouting of where the catheter is positioned, and rather than going up through the urethra, it's put in above the pubis, so suprapubic, through the skin and directly into the bladder. It uses the same catheters, like literally they're the same catheters as a urethral catheter would be, same devices. There are ones that are being invented, but none of them are here yet, so we use the same devices that we have. It engenders with it the same risks of urinary tract infection, although that has been on and off in the literature, okay? Some areas will say that the urinary tract infection risk is less. Yeah, the bacterial flora may be different, but the same rate of infection occurs, so that's not necessarily true, so that's a false, I guess, reason to do it. The other thing, sometimes people will say, does it cause fewer bladder spasms? Again, untrue. Although I do see in the population that I put suprapubic tubes in, and I do that a lot, they do seem to have fewer bladder spasms, at least for a year or so. I'm not sure if that's just, you get to reposition the catheter so it's no longer in the same place and irritated. The real driving reasons to do it are for comfort. Okay, so if the catheter is being in your urethra and near the genitalia, and even for intimacy reasons, if it's bothersome that way, that's a reasonable reason to move it. Sometimes it's for a difficult catheter, so someone it's very difficult to change their catheter through the urethra. We can change it suprapubically. But apart from that, those are the main reasons to do it. Okay? Does that answer your question? Or?
Can you still have leaking problems even though you have the suprapubic?
Absolutely, yeah. I mean, it doesn't necessarily eliminate those urethral leaking issues, because the same factors still come into play, and especially in someone who has a urethral catheter chronically. And see, the unfortunate thing in the community, and I was trying to sort out a way to get this out there, but there are a lot of care providers who will erroneously assume, and I get this logic, it makes sense, that if you're leaking through your urethra, well then why don't we increase the size of the catheter? I mean, I get that. The problem, or the other one that's commonly said, is why don't we increase the size of the balloon or fill the balloon up more? I mean, I get that logic, but the unfortunate consequences of that is things get worse and worse and worse, and the urethra gets stretched further and further out. And so for people that's an issue, those are important people that I like to catch and convert over suprapubic, because if I can convert them over quickly, we still retain a lot of strength in their pelvic floor, so that that catheter isn't injuring their urethra and outlet. That happens more in women than men, that's for sure. Okay, so in early intervention, these things can be corrected to help that suprapubic keep you dry, but there's a little more work involved.
With regards to the suprapubic, the positioning of it, in my wife's case, is rather low. And one of the things that we've had problems with is that her belly roll is sort of cramping it and therefore stopping it. And so I guess my question is, can that be moved? Like, can you sort of move it up or to the left or to the right or whatever to
It's
facilitate that?
It's very difficult because there's not a lot of pathways that we can use. The problem with its location is very specific to try to get it in the center of the bladder in a certain location. It can be shifted a little bit to right or left, but in the end, internally, that does very little difference. We can't tunnel it through very much adipose tissue because the track will be lost when we're changing it. So it becomes a very difficult catheter to change. So that is a limitation of it for sure. Yeah, for certain. The other problem I see with patients as well is also the location that the catheter is aimed at internally, which is a bit of a random event. And some people, unfortunately, it hooks back and almost is aimed out their urethra, by bad luck or by the way their bodies are positioned. And so that's another example where, hey, if we could redirect that, that'd be wonderful, but it's very difficult to do. There's just a problem with the catheter and mechanically.
I wanted to ask about the Botox injection.
Yeah.
Does that help with urgency?
It does. I mean, with a proper evaluation, most people need to be evaluated to see what the basis of their urgency is, because not everyone has what the Botox is targeted to, which is an overactive bladder. Usually it's used as a secondary line at the very least. You have to try one of the medications at least once before we move on. But basically, yeah, it could certainly help, and it is very effective in people with NS. Certainly a very good option. It's now also being used with people with what we call idiopathic overactive bladder, so people who have no neurologic condition but have this same issue, which they do have. And that just underlines its safety and how effective it is. Yeah, it works very well as a second line.
Hi, you being the specialist, how long would it take for one to get an appointment with you? And would you have to go through your doctor, family doctor first?
Yeah, there has to be a primary referral, so it can be your neurologist, family doctor, or you can find a resident who will sign it for you. They'll do that too. But basically, it's about 3-4 months.
3-4 months?
Yeah.
Thank you.
I was just wondering, when you can sit on the couch and you're watching a TV show or something, the second you stand up, it's like the floodgates open. It's like someone's, oh, she's up and moving, let's get her.
I hear that every day.
What does that cause from? Is that just...
It actually could be multiple things. It could be that with a very full bladder, as you've moved up, it's triggered a bladder contraction. It could be from the strain of standing up causing stress incontinence.
My daughter said she was going to put me on a pee schedule. So every time I go near
that
the
does sometimes work,
For Eric, what was the name of the new drug that doesn't have side effects, even if it's not out yet?
Well, no, it's out.
Oh,
It's out. It's been in Japan for about 3 years,
Okay.
US for 2, here since January. It has side effects, but they're very few. It's Mirbetriq. Yeah.
Okay. And Krista, when you were showing squatty potty,
Yeah.
which one was the right position? Was it the one where you were leaning like that, or did you want?
When you're
someone
leaning
to
forward,
Oh.
is that it? Yeah, so you want your feet supported a bit higher, sorry. You would have your feet supported and you're leaning forward and relaxing the abdomen. You don't want to be tensing the abdomen pushing because that sometimes has the pelvic floor pushing up with it. You want to relax the abdomen, relax the pelvic floor, and let the bladder, the bowel do the pushing.
Okay, so that's why those new toilets aren't.
They can make it more difficult sometimes, yeah.
Some of those new toilets, they're so high. If you sit on them and your feet are not even touching the floor.
Yes,
That's right.
that makes it difficult, yeah. So that way you can sit down, bring it out, put your feet, and then push it back, and then stand back up again.
The spasms that you were talking about, is it the bladder itself that spasms? Is that something that you can feel, or does it happen without you realizing it or knowing
So it is the bladder.
Like your leg or whatever?
Yeah, no, it is the bladder itself that's spasming. And I mean, your perception of that, most can feel it, but again, it depends on, you know, if you do have some kind of injury to your neurologic system. If it happens to be the sensory side that's injured, you may or may not sense it in the same way other people do. So it depends. In some patients, for instance, that I treat who have, you know, complete spinal cord injuries who have this, they don't really sense what's going on. They just see the result of urine being expelled.
What would the sensation be?
Well, like we described, usually it's urgency, frequency.
Oh.
Yeah.
Back to the medications, I heard that like diptaphane and some of them cause increased chance that you get an Alzheimer's. That people have been, the older population has been being taken off diptaphane. Do all of those medications have that side effect?
So none of them cause Alzheimer's.
Not
They
cause, but contribute?
Yeah. So the paper was on oxybutynin, which is one of the old ones.
Yeah.
And it relates to further confusion. And so the idea there is in the elderly, especially those at risk for confusion, we probably should avoid some of the older generation medications. Now these companies have become, you know, as the newer versions of them have come out, they finally have started to come out with papers addressing this and checking it. And it doesn't seem that the newer generations cause any confusion. So just to be clear, it does not cause Alzheimer's.
Krista, I think you've already addressed the issue, but I'm getting up from my nocturia. Get up, have to go back into bed, have to go again immediately. As soon as you change, as soon as I lie down, you know, I mean, it's just like, and I know it's the first time I'm not finished. As soon as I lie down and change position, it's going to happen again.
First of all, you'd want to make sure that you are actually urinating properly, that you don't have a retention problem, so that you are voiding properly. After that, if it is just an urgency and you're waking up and what you want to do is not be, again, tensing and worrying and whatnot. You want to be trying to relax the body and thereby relaxing the bladder so that it can relax. If it's not in a true spasm, if it's just an urge and you go there and it kind of come and go, then that is something you can sometimes relax through, distract through, and try to not go every time the bladder stretches, but try to calm that down and wait till and try to get back to sleep and not race. You can train yourself to get up over and over and over just by going every time you have a small stretch of the bladder. Does that answer your question?
I seem to be having an issue with two-stage voiding. I'll get myself onto the toilet, I sit down because I'm kind of uncoordinated and can't stand up and pee at the same time. I more or less empty the bladder and then I stand up to pull my pants up and I've got to go again and I go back. And sometimes I will complete the voiding by doing it standing up. That introduces problems of its own when stuff dribbles down to your leg rather than into the toilet bowl. Is that an unusual conundrum?
It definitely can be. It's not unusual, and men and women both can experience that. They're sitting. Sometimes it can be due with the positioning of the bladder. When you get up, it changes position.
Yeah.
It can be that your sphincter is not coordinated, so your bladder's contracting, and then your sphincter decides to contract at the same time. So then you have to maybe sit there and then try to void again to see if you can get your pelvic floor in that sphincter to relax again to finish the void. So you might want to sit and try again. You do not want to be pushing to try to be voiding it, but you try to relax the pelvic floor, try to send down the signal again for that to contract and this to relax, and that can sometimes help. But it is definitely common. And it can be that your bladder is pushing and then it takes a break because it's not very strong and your pelvic floor and whatnot is contracting. A lot of times people sitting down can relax their abdomen and their pelvic floor better so that they can urinate. So that is sometimes, if you're having difficulty standing, they'll say sit. So that can be helpful.
Well, easier to start out sitting, but I kind of end up standing to complete the void.
Yeah. And I think it would be very important to make sure that you really are emptying, or that you're effectively. And there's very few other ways of doing that than just kind of recognize that with your family doctor or neurologist or one of us, and to look into it. I think it would be very helpful for you to understand that better.
Okay.
But it is very common.
I've managed to get control over getting up in the middle of the night most of the time, but I find that when I do end up having to get up and void in the middle of the night, it's usually because I have spasms in my leg. And the only way I can get rid of the spasms in my legs is to get up and void. Is there any other possibility of solving that problem?
And this may be an example. I mean, it's a bit of a combination of things. It may be an example of some form of functional incontinence or functional problem. But I mean, you're saying that basically going to the washroom, let's just stretch the legs out and get you back to bed. Yeah. Sometimes leg spasms can be related to other issues, and again, it may be helpful to talk to your family doctor about that, because yes, there are things you might be able to take, to help you specifically with leg spasms. But it's not uncommon, and sometimes when we look at people getting up at night frequently, the bladder certainly gets blamed, but there are a lot of other causes like leg spasms and sleep apnea has come up a lot in neurology lately as far as
Yeah, well, I already take 6 pills at night to help deal with the spasms.
Yeah.
Baclofen and Tizanidine.
Could you explain a little more about the patch?
So so the oxybutyn patch was very popular. It was fantastic, and there's been 2 versions of oxybutyn. It's a drug, and it's actually quite an old drug. It's that same drug that was causing confusion in patients, actually. But for some reason, in the mode of delivery through the skin, it seems to eliminate a lot of side effects. It's actually quite dramatic. I think it's almost 1/8 of the side effects from it. The pitfall of the patch, which is almost non-existent on the shelves anymore, was that it was causing a lot of rash or dermatitis around the site. So it was doing very, very well, and then all of a sudden, within about a year or so of use, it started to become very unpopular because of this problem with applying it. People were running out of places that they weren't reacting to with it. So more recently, there's a gel. It looks like that sanitizer gel we all use at the hospital, or at least I use it every 15 minutes or something. But same kind of basis that's applied to the skin. Seems to work just as effectively as the patch did. It does apparently cause pruritus or itchiness as well, but I haven't seen that yet in any patients, and just as effective. Now, its downside is it's not covered yet. And it seems in Canada that the real call sign if something's going to be covered soon is if Quebec covers it, and they haven't done that yet. Okay, it's quite costly. I think it's over twice as much as one of the pills for cost. So I think that's maybe why they won't cover it very easily. But it is a fabulous medication, a fabulous mode of delivery.
And this would be for urgency also?
Yeah.
Chris, is there an optimum height for the little step you were describing to have at your toilet? Or?
It would, again, be how high is your toilet to start with. If it's they do sell them in 2 heights. We have, I think, the 6-inch one, but there is an 8-inch one that we don't have at our clinic. So if you're having a raised toilet seat, you might need a higher one. With a regular toilet seat, the 6-inch should be good.
Sorry, can you spell the name of that new drug that works?
I'm not sure if I can. No, Myr, M-Y-R, Betrick with a Q. Betrick, Myrbetriq. It's also called mirabegron, but I think that makes it worse. You have to be careful with the mirabegron version because it sounds a lot like a chemotherapy agent, so that's why I tell people to stick with Myrbetriq. I think if you just speak to probably your family doctor at this point or a urologist and you just ask them for the new one, the really new one, they'll probably know what it is. Okay. Or you can remember it's the first beta agonist, beta 3 agonist. Is that easier? Yeah. B3, say it.
It'll be on the slide.
It affects the B3, yeah. But by the way, the names of drugs are going to start getting worse and worse and worse, and it's because we've basically run out of names that are not similar. And so what's going to start happening is there are going to be actually digits, I think, thrown in. It's going to become very odd. And that's, for example, I don't know if any of you have or are on Cipralex, but it's very similar to, say, Cipro, the antibiotic. And I've seen some people treated for urinary tract infections with antidepressants. So that's why that kind of weird name comes out. It's quite distinct, but not easy to remember.
Thank you. Well, thank you very much, Krista and Eric. Now I'd like to present to you our next presenter, which is Adam Goldberg, who is a major fundraiser for the MS Society. He's been actually the top fundraiser for the MS Walk for 8 years, raising over $54,700. He's here today to talk about his personal experience with bladder incontinence. Adam?
Thank you very much. I'm sorry I don't have a PowerPoint presentation, just have the old-fashioned notes. Is Lori on? Oh. Now you broke it. There we go. There we go. When they asked me to do this, they're like, you'd be easy for this. You do improv theater, no problem. But I find this is a very daunting subject, speaking to you all here tonight, talking about me and my MS. I was diagnosed just under 10 years ago, and bladder issues have always been my problem. For me, it was waking up in the middle of the night, having to go, and not being able to go, and then standing, waiting, doing all the counting games you want. And all of a sudden, Niagara Falls, it was bliss, and then you'd go back to bed, and I'm thinking to myself, what's a 29-year-old having this type of problem? And one day I had to go to the ER because I couldn't go at all, and then after they cath me, and they're like, wow, you've got 2 liters of urine in there, and it's like, okay, let's get your MRI results. Oh, presto, you've got MS. So it was all that, all at once sort of thing is that sort of led to it. And then I was been treated with medications because of bladder spasticity. Basically, Dr. Sawtelle spoke about you can either have one side or the other side, you know, you either not going or you're going too much. That's me. I've had basically all of the above, where, you know, give it 12 hours and nothing, or give it every 5 minutes. It's like, oh my gosh, that alarm bell is going off in your head. So I've had it all. I've been dealt with medications, and as my MS has progressed, that's the one thing, the invisible symptoms I live with MS, it's the bladder. Nobody sees it, but I feel it. So basically, I was referred to a urologist, and then with cystoscopies, ultrasounds, and stuff like that, it was basically deemed necessary that I start catheterizing, and that led to once a day, then twice a day, and currently it's 3 to 4 times a day. To me, it's just part of life now. It's, you know, it's something you have to do. You brush your teeth. For you people with hair, you comb your hair. Me, I have to cath 3 to 4 times a day. It's just part of life. You know, at first when I was told you got to start cathing, is it frustrating? Yes, but in the end of the days, it's like, okay, it just incorporated into part of the routine. Let's see here. It's the scheduling and planning. That's what I got my notes here. That I'm basically more cognizant of that, okay, about every 8 hours I will have to catheterize. No big deal. It's not like I have to announce it to the world. But by the same token, if I'm traveling, going away on holidays, that sort of thing, you have to sort of, you know, don't plan this for, you know, don't go on a big road trip unless you have catheters with you. And it's not like, oh my gosh, I have to carry a big travel bag worth of something. No, it's just carrying a knapsack or carrying a laptop bag or something like that. So it's not much of a problem. And Dr. Sawtelle spoke about this, and Chris also spoke about this, the embarrassment. You know, we all have to pee, people. Whether you have MS or you don't, we all have to pee. So people is like, oh, I can't tell people I have catheters because it's embarrassing. Well, so far, I don't recall anyone I've mentioned that I have to catheterize. I'm like, oh, wow, you're a loser, or we're going to tease you or anything like that. I've been embraced, basically. It's like, oh, is there anything we can do to help you? You know, it's like, oh, you know, like I've been offered like special rooms and stuff like that. It's like, no, I just need to use your bathroom when I have to go and that sort of thing. And it's pretty much, it's part of life, and people are understanding. There's nothing to be ashamed of. You know, accidents happen. You know, I wet my pants. There's a lot of people, you know, that have wet their pants whether they have got MS or not. So again, it's don't let the stigma of like, oh, I've got a bladder issue, so I'm going to stay at home. No, don't let that bug you. It's just, you know, it's like when I tell people that I have MS, you know, it's like, oh, you must feel really sorry for yourself. Like, no, I don't. It's because as I tell people, you're going to either let it beat you up or you're going to beat up MS, and that's what I do. I fight it, and that's what I do with the bladder thing. It's like, I'm not going to let it control me. And that's about it. Thank you. Or, are there any questions?
Thank you very much. I went through a period of self-catheterization for quite a long time, but then wondered whether or not it was not causing more problems than it was curing. I wasn't quite sure whether I was getting infections because of the catheterization, and I thought I was being pretty good in my sterile technique or whatever, or whether I was just getting false alarms because of irritation of the urethra. So I basically stopped. And found that I can do reasonable control by timing when I drink. So that if I'm going to go out, I don't drink for 24 hours beforehand, significant amounts, but then I obviously load up when I'm going to be around. So there's another option, and obviously, as you said quite clearly, this is certainly nothing to be ashamed of.
No.
But also individuals react in very different ways to many of these things.
Yeah.
Yeah.
Myself, if I were to not cath for one day, I would notice it. So I don't have that luxury. You know, as Kristen and Eric have mentioned, you know, you're watching your liquid intake. There's been days where I've had liters of water, and you know, yes, I'm going more. And then there's like the gentleman referred to, where he's drank absolutely nothing, very little, and then all of a sudden it's like that urge. And that's just the wonky way MS works on the bladder, is that it's unpredictable. So I've been fortunate that, you know, my cathing techniques, I would assume, are good because I haven't had any UTI problems or anything like that. I guess I wouldn't stop cathing just for the sake of convenience per se. Anyone else? Oh, question back.
Are you changing your diaper, Nana? I was like, would you like to just calm down, because I don't want everybody on the floor to know. When you're 4 years old, they think it's quite a hoot that Nana's wearing diapers too, and she's out of diapers now, so.
Well, when I was like the medication they first prescribed me is called desmopressin, or DDAVP, and it's the medication they used to give kids to stop wetting their beds. So I'm thinking to myself, this is great, you know, way to make me feel younger. I'm getting the medication they give to 8-year-olds. So, you know, that's the way
I always say when you get older, it's the golden years, but the only thing golden is your pee.
There you go. There you go. My one shameless plug, if you haven't considered doing the walk or the bike, the only way we raise money is by raising money. I urge you, do what you can, participate in the walk or the bike, because it's by fundraising, we're only going to get cured.
Thank you so much.
Thank you.
Thank you very much. That was wonderful. Our last presenter now is Fiona Sparrow, who was unable to be here today, but gladly created a YouTube video about her experience after hearing about our presentation from the MS Clinic. She is an active blogger, and you can access her blog at the address up on the screen after the presentation. And then Lori just wants to add a little something. Thank you.
So when you start watching this video, you'll hear Fiona refer to herself as having malignant MS. And when our education committee previewed the video, there was a little bit of concern about that terminology. And so I decided to contact the MS Clinic and get their views on that terminology. And this was the response I received. Technically, malignant MS isn't one of the usual subtype classifications of MS. It is just an expression that an individual is following a very severe and rapidly progressive course of the disease. So it's a much more aggressive, progressive type of MS. So this is Fiona.
Hello. I'm pretty certain I've already been introduced, but my name is Fiona. I am a patient of Dr. Baverstock's in Calgary, Alberta at the Rocky View Hospital. He is the doctor that does my Botox. He's been doing my Botox since 2009. It has only been the last 2 sessions that have not caused me to become ill. This is due to my malignant form of multiple sclerosis, and my bladder ran my MS. And so every time I would get a Botox between 2009 and 2011, I would end up with a UTI. And then I would end up hospitalized, I would end up paralyzed, and then I would end up with an indwelling catheter, and so it really all defeated the purpose. Since my transplant, I had a bone marrow transplant, stem cell replacement for malignant multiple sclerosis, with Dr. Atkins and Dr. Friedman in Ottawa. And I, since then, have had 2 bladder Botox, and they have been heaven sent. I, for the first time, a couple of weeks ago, started going to bed without a diaper for the first time in 7 years. I no longer need to wear pads at nighttime. I am pretty self-reliant at this point, and coming from a girl who was a quadriplegic, and my autonomic system was shutting down, and my smooth muscles were not working at all, and that does not happen for me anymore. And since my last Botox, which, pardon me, was the 7th of September, and like I said, I have been diaper free, and that has not happened in many years. The procedure itself certainly gets your attention. You go to the doctor's office and they take you into a room, you change your clothes, then you go into this room, then they lay you down on the bed and they strap my feet down, and because when they stick the needles in, my legs will go into spasm and I can kick them. So they strap you down, and then they put on an topical freezing cream, and that stays on for about 4 to 5 minutes. They'll cath you to drain, make sure your bladder is emptied. And then from there, Dr. Baverstock comes in and he puts a little light with his needle. They put in 20 shots of Botox into my bladder. I have no idea what they do with other people. And from there, when you first walk in, I'll go back a little bit, because when you first walk in, they give you an antibiotic called Cipro, and it's to prevent the urinary tract infection, or try to. Now it works for me. Before the transplant, it never did. That simply is because my body was so ornery. And I just hope that, it is my hope that in Ontario that doctors start to do this, because for patients with incontinence, there is no greater blessing. And it's freedom. And for anyone who knows how embarrassing it is to wet your pants or overflow a diaper or avoid leaving the house for fear of one of those things happening. Diapers are wonderful as far as they go, with the exception of when you sit. When I was in a wheelchair and laying in bed, or when I'm laying in bed, it was never bad because it fills your diaper. But when you're having to sit up, a diaper only holds so much fluid, and then you have it coming down, and it's just a mess. And people are afraid, and they don't want to leave the house. They don't want to be embarrassed or ashamed, and it's horrible to be that person where you can do nothing about where you're at. And incontinence with multiple sclerosis is hardwired, and it's difficult for anyone to be okay with what is happening. And so for me, I had only been diagnosed a year before I was in diapers. Like I said earlier, I've been in them for 7 years, and it's only now been 2 weeks. And for me, there's no freedom. There's no freedom like it. And I still catheterize to go to the washroom. That's how I have to go, because my bladder does not empty properly. And so for the freedom of not getting UTIs and all that stuff, I catheterize 5 to 6 times a day. And I don't need to protect myself anymore. And it's just wonderful. So I don't know if this is what you need to hear. I'm not sure if I have filled you in on enough information. I just know that this is my story, and that Botox is freedom. And freedom from MS, for an MS patient, is hard to come by. So this is just one stepping stone to a better life. And so for me, it has done countless good things. So thank you very much for your time, and I hope you have a wonderful meeting. And I'm coming to you from Alberta, and I'm just really grateful that I can be here to help. Thank you for your time. Have a great day.
Well, thank you to Fiona for taking the time to create that video for us. She's given us permission to share her contact information, available on the screen with you. Yeah, is it there? Yes, it is. Okay. So if you have any questions, actually, you could contact her. This information can also be found on the resource list that's distributed in one of the papers that, no, it's not there. I was told that it's not. Okay, so if you want to have this information, I would encourage you to note it down on one of your piece of papers. So that actually concludes the presentations for this evening. I'd like to thank everyone for coming out tonight. One more thing I'd just like to ask you not to, if you could, please not forget to fill out the evaluations if you have not done so. And then you could just leave it on the chair if you want to give it at the back. You can either, yes, okay. So thank you very much. Oh, and there's also some pamphlets on the table at the back, information pamphlets on Botox. Again, if you had not had the chance to maybe grab a little granola bar or have some cranberry juice, there's still some back there, or in some water. So yeah, so thank you very much for coming this evening.